electron beam computed tomography is a very exciting imaging modality which provides anatomic and physiologic information about the cardiovascular structures. When we mention anatomic information, is that the structure of the heart and the detection of calcific deposits in the coronary arteries are exquisitely detected by this modality of examination. And when we talk about the physiology of the heart, we refer to contractions of the heart muscle, the dynamic studies of the atrioventricular valve as well as of the aortic valve, the study of flow in the heart and in the coronary arteries, as well as myocardial perfusion and in the postoperative heart flow determinations at the level of the grafts. We are now going to describe the short axis images obtained with this scanner. The short axis image is obtained by rotating the table 25 degrees to the patient's right and tilting the foot of the table 15 degrees downward. In this level 1, we can see the aortic valve leaflets and the aorta sitting in the center of the heart. The opacified structure behind the aorta is the left atrium, and ventral to it, the unopacified right ventricle. The second level is caudal to the first one, and we begin to see faintly the right coronary artery arising from the anterior sinus of Valsalva. We can see the left atrium behind the aorta and the left ventricle to the left of the aorta. In the third level, we see faintly the aorta, distinctly the left atrium, and some contrast is noted in the left ventricle. In the fourth anatomical level of the short axis, we see opacification of the left ventricular chamber and filling defects that represent some of the papillary muscles. In the fifth level, we see distinctly the plane of the interventricular septum. We note to the left of the interventricular septum the opacified left ventricle, and to the right the unopacified right ventricle. Going to level 6, we see faint opacification of the left ventricle, some degree of opacification of the left ventricular myocardium, and the filling defects from papillary muscles in the left ventricle. Level 7 is one of the most caudal sections, which show the right ventricle opacified, a filling defect that represents the moderator band, and the faint opacification of the left ventricle. And the last slide shows the right ventricle opacified as well as the left ventricle, and note the liver in the left side of the slide or in the right side of the patient. The long axis is the so-called four-chamber view, as seen also with echocardiography, and is the best projection for evaluating the totality of the left and right ventricular cavities and the outflow tract of the two ventricles. In order to position correctly the patient, the imager keeps the scanner table level but moves the table 25 degrees to the patient's left. This produces a projection where the heart is more or less parallel to the scanner gantry, and the ventricles are clearly depicted, again somewhat similar to what one sees in the long axis view on echocardiography. On the long axis level 1, we can see the ascending aorta. We note to the left of the ascending aorta the outflow tract of the right ventricle, and we can see to the left of the right ventricle the left ventricle. We note the projection of the superior vena cava just behind and to the right of the ascending aorta. We can also see in level 3 the outflow tracts of the right ventricle, the left ventricle with the filling defect that represent the papillary muscle. The left atrium behind is the dorsal chamber and the superior vena cava, and a portion of the right atrium close to the right heart border. In level 4, we see the filling defect in the right ventricle that represents the moderator band, the interventricular septum, which appears non-opacified, the left ventricle, and then we note behind the right ventricle the ascending aorta. Behind the ascending aorta, the superior vena cava, and the most dorsal chamber that we see is the left atrium. In level 5, we see the outflow tracts of the right and left ventricle. We note the ascending aorta behind the right ventricle, the superior vena cava to the right and behind the ascending aorta, and the opacified left atrium with the entrance of the pulmonary veins as the most dorsal structures in this plane. In level 6, we see distinctly the right and left ventricle separated by the unopacified interventricular septum. We can see the superior vena cava with the contrast as well as the right atrium in the region of the right auricular appendage. In level 7, we see more contrast in the right side of the heart. We see the right atrium and right ventricle, and the unopacified left ventricle is seen to the left of the right ventricle. And finally, in the 8th level is the most caudal portion. We can see the right ventricle opacified with the right atrium above it, and we note the right atrioventricular groove, the home of the right coronary artery. In addition to the short and long axis images, the most common utilized are the neutral axis images, which means that the patient is lying perpendicular to the gantry and parallel to the floor. There is no tilt of the table. And the anatomy of the heart in this projection is about the same as with the short axis. This is the position of the patient used for the ordinary calcium screening studies. We're going to show now representative cases that reveal calcification of the right coronary artery. The first two images show calcium in the wall of the ascending aorta and also at the origin of the right coronary artery. The next two images show, the one to your left, a fleck of calcium in topography of the right coronary artery, and the second image, a heavily calcified coronary artery. Dr. Arthur Agatsson, a cardiologist who is very close friend and works with us, and Dr. Janowitz, Dr. Sussmer, and myself designed what is called a calcium score index, which measures the area of the plaque and multiplies it by the Hounsfield number, that is the density, the area of the plaque, and by the number of plaques. The machine can electronically calculate and add all these area, and in this way we can establish what is called the calcium score index, which reflects the severity of coronary atherosclerosis. The image that we are showing now represents 4 sections of the heart where we can see the distribution of calcium in the right coronary artery. The next image shows electronic reconstruction at the origin of the right coronary artery. Notes the eccentric plaque formation. Minimal changes secondary to atherosclerosis are characterized by punctate or plaque-like calcifications, as noted in this image. However, the absence of calcific deposits doesn't mean that the coronary artery is normal. We have seen that fatty streaks produce inhomogeneity in the density of the coronary artery, and this must be consistent through several cuts, and we believe that the inhomogeneity is related to fatty deposits and not to organized plaques. The next 4 images reveal calcification involving the main left as well as the left anterior descending branch of the coronary artery. We can see in the 4 images the distribution of the calcific plaques and the involvement of the left main trunk. We can now see in this patient spotty areas of calcification of the left main and left anterior descending. The next image shows a heavily calcified main trunk, and the last image, the bifurcation of the left main trunk, where we see calcium in the left anterior descending and in the circumflex branch of the left coronary artery. When the left main trunk is heavily calcified, it may be associated with a stenotic lesion, and these are individuals at high risk. In some instances, they can be dilated, the areas of narrowing. In other situations, they may consider a quick bypass to prevent massive infarction due to sudden occlusion of the left main coronary artery. Calcification of the left system, which include the left anterior descending, the circumflex, the main left, and even the diagonal branch of the left anterior descending. These are individuals that should be put on a risk factor modification regime to stabilize the abnormal lipids in the blood, the correct high blood pressure, exercise, diet, lifestyle modification, and repeat the study of the heart over a period of time, at least once or twice a year, to establish if there is progression, stabilization, or regression of the coronary atherosclerotic plaques. Finally, these last two cases show the first one, a fleck of calcium in the main branch of the left coronary artery, extensive calcification of the left anterior descending, and the second case shows plaques in the circumflex and in the left anterior descending. But note the very small area of the right coronary artery. This patient had a massive occlusion of the right coronary artery some years before, and his heart was dependent on the patency of the left system, which, as you can see, shows calcium in the circumflex and in the left anterior descending branches of the left coronary artery. This is a patient who is at risk of developing a heart attack that may be fatal, and also a possible a fatal cardiac arrhythmia, in view of the fact that his heart is dependent on exclusively the left system. Other morphological studies that can be obtained with ultrafast computed tomography is what is called electron beam CT coronary lumen imaging, or intravenous coronary angiography. 0.1 second scans are triggered by the electrocardiogram. There are 40 1.5 millimeter slices at 1 millimeter steps following the intravenous injection of contrast material that is injected usually with a non-ionic agent at a rate of about 3 milliliters per second. The 3D display uses experimental MIP and hybrid surface techniques and can be obtained quite quickly following the completion of the study. These are images that we obtain courtesy of the Imatron Corporation, where we can see the 3D images of the coronary arteries in various projections. These are images of patent graphs courtesy of Imatron, and where they were taken at the Heart Institute in Beijing, China, where I had the pleasure of being a guest speaker in the month of November of 1998. Note patency of grafts that extend from the aorta to the right coronary artery and to the left anterior descending, and note a lima, that is the left internal mammary artery, connecting to the branch of the obtuse margin of the heart. In the other image, we can see two grafts, one to the LAD and the other one to the circumflex branch of the left coronary artery, going from the ascending aorta in front of the right ventricle and pulmonary trunk and ending in the coronary artery. This second application of ultrafast computed tomography is the functional study of the heart. We use the R wave of the electrocardiogram to trigger the imaging sequence. We can diagnose cardiac abnormalities that are characterized by changes in the chamber volume, myocardial mass. We can estimate ejection fraction and stroke volume, cardiac output, and determine regional myocardial morphology and dynamics. Also, valve abnormalities and pathology of the aorta and other great vessels can be depicted very readily, particularly if we project the image in a cine loop showing the contractions of the heart. The next 7 images are cross-sectional studies that show the left ventricle in systole and diastole. If we record the ventricle in systole and diastole, electronically we can calculate the ejection fraction. Note the tracing on the bottom left of each of the images. If we project these images on a cine loop, we can see the contraction of the heart as if we were doing an angiocardiogram. This is a tracing of a normal left ventricle. Note the position of the endocardium in systole and the position in diastole. We can estimate the ejection fraction by comparing the ventricular cavity in diastole and systole. This is an example of a patient with a normal ejection fraction. Note the marked reduction of the cavity of the left ventricle at the end of systole. This is in contrast with the next case that had a poor ejection fraction. This patient had an ischemic cardiomyopathy and the left ventricular cavity fails to empty as readily as it should, and the machine can electronically deliver this type of information because it adds all the parameters when one studies the left ventricular chamber from the base of the heart all the way to the outflow tract of the left ventricle. These are 2 echocardiograms which show to your left the 4-chamber view and to your right a 2-chamber view. Note the normal contraction and emptying of the left ventricle. To your right we can see in profile the plane of the mitral valve. And the echogenic area is the diaphragmatic surface of the left ventricle. This is a patient with cardiomegaly and a calculated ejection fraction of 30%, which is obviously low. Note enlargement of the chambers. The left ventricle shows an akinetic septum and a hypokinetic apical portion of the left ventricle. Note to your right a hypokinetic diaphragmatic portion of the left ventricle. To your left a normal heart, and to your right the enlarged left ventricle with the areas of akinesis and hypokinesis that we previously described. The standard scintigraphic examination of the heart consists of static and dynamic, often multi-dimensional images of the heart with a special emphasis in the left ventricle. We're going to show you now a gated SPECT technetium 99M myocardial image. To your left, the ventricle in systole. To your right, the ventricle in diastole. To your left, the green area represents the excursion of the left ventricular wall as it goes from systole to maximum diastole, which is what we see to your right. And now you can see the contractions of the left ventricle. Note that we can see that in one plane or multidimensionally, as demonstrated in this cinematic display. These images reveal an area of hypokinesis in the anterior lateral portion of the left ventricle close to the cardiac apex. So this is a region that does not contract as energetically as the rest of the ventricle. In this case, we can see the abnormal left ventricle in the upper image with the area of hypokinesis close to the left apex, and below we see the long axis of the normally contracting left ventricle. Radionuclide ventriculography, ultrafast CT of the heart, and cardiac MR imaging appear to be competing technologies. For example, when evaluating left ventricular ejection fraction, the 3 technologies may show variations that are within 7%. When looking at the ischemic heart, we must differentiate the wall motion abnormalities that are related to scarred non-viable tissue from the viable hibernating myocardium. The latter can be revascularized, and sometimes we can use stress tests, be that echocardiography or using radionuclide studies or MRI, such as the use of dobutamine, to determine if the area of hypocontractility is a transient or a permanent abnormality. The following represent two examples, one of a normal heart and the second one a study done with myocardial tagging in a patient who suffered a myocardial infarction. You will note the normal contractility in the first examination. In the second patient who suffered a myocardial infarction, one can see the lack of motion of the cardiac tags at the infarcted site. Left ventricular dysfunction is usually the sequela of myocardial ischemia. However, occasionally we can see right ventricular dysfunction as illustrated in this case. And note the dilated cavity of the right ventricle, which is markedly hypokinetic. The third application of fast CTs of the heart is for blood flow studies. One can study regional myocardial blood flow, that is the perfusion of the myocardium, as well as blood flow in coronary bypass grafts. The graft patency studies can be complemented by flow determinations at the level of the graft. And finally, we can study shunts within the heart or outside of the heart. This next image shows how we perform the myocardial perfusion examination by placing cursors at the level of the various aspects of the left ventricle. Using a time density curve, one can compare the arrival, the peak density, and the disappearance of the density of the contrast material as it traverses the myocardium, an indirect way of evaluating the perfusion of the myocardium. Myocardial blood flow and myocardial perfusion can be predicted on the basis of scintigraphic examination, particularly SPECT studies, and lastly, myocardial tagging using cine magnetic resonance imaging can also correlate with regional myocardial blood flow perfusion abnormalities. SPECT images are demonstrated in the three rows of scintigraphic examinations of the left ventricle. This is a normal patient. Note the superior row represents the short axis. It is an axial view, looks like a donut of the left ventricle. And then the middle row represents the vertical axis, and the bottom row, the horizontal axis. These images are following stress that can be either exercise or pharmacological. Note that there is a normal perfusion of the wall of the left ventricle. In this patient with myocardial ischemia affecting the diaphragmatic and lateral aspect of the left ventricle, we see first the images with the patient at rest. Note the images following stress. There is evidence of hypoperfusion of the diaphragmatic surface of the left ventricle, as well as the free or lateral wall of the left ventricular chamber. Note to your left the normal left ventricle at rest and during exercise, and to your right the ischemic left ventricular chamber during rest and exercise. These are composite images of a normal left ventricle as far as perfusion and contractility. Note the various axes of study of the left ventricular chamber. In this patient with myocardial ischemia, we see hypoperfusion and hypocontractility in the region of the ischemic portion of the left ventricular chamber. The upper two images show hypocontractility due to hypoperfusion. The bottom images reveal normal perfusion and normal contractility of the left ventricle. Single and multiple grafts can be opacified when contrast is injected intravenously. And these are three examples that show first the patency of the graft, and the last two images reveal the flow in the grafts that can be determined by placing cursors at the level of each of the grafts. So one of the advantages of flow studies is that we not only can see the patency of the graft, but estimate the blood flow through the graft. The first case represents a ventricular septal defect. The site of the jet is illustrated in the top images. The second image is of the ventricular septal defect in another patient, showing a jet at the level of the mid portion of the ventricular septum. This is a common cause of a holosystolic murmur, and it's called the Roget disease. The third is an example of an atrial septal defect, where the right atrium is quite large, and one can see the communication between the atria. These communications are best analyzed when contrast material is injected. And finally, the last case is of a patent ductus arteriosus. Not only can we see the communication between the aorta and the pulmonary artery, but we can quantitate the shunt doing densitometric curves.